So we hear a lot about drug treatment, but actually surgery is the best treatment for GISTs. Surgery, of course, is the physical cutting out of a tumour, and this may require quite extensive resections, and a lot of you are living with this, so you know all about it. In some cases, patients will have had the whole of their stomach or part of their stomach taken out, sections of bowel, pancreas and spleen. Some patients suffer the long-term consequences of this treatment. For example, if they've had a gastrectomy, they will have symptoms as a result of that are lifelong. They may have a stoma, etc. The extent of surgery is limited by the involvement of adjacent organs, and sometimes it's just not possible to remove a tumour, even if it's only a primary tumour, because it's stuck down to major blood vessels, for example. But surgery is the best treatment because it's potentially curative, and at the moment it's the only curative treatment that we have. So I think it's really important. I do drug treatments, but I have to keep reminding myself, actually, more patients are cured by surgery. But of course, as Maria's already told us, it's unlikely to be curative for multifocal or metastatic tumours, although those of you who've been on treatment, drug treatment for over 10 years, probably thinking, am I actually cured now or not? We don't know, but really and truly, the best treatment, if it were possible, would be surgery. And here's just some pictures of operable GIST tumours. Maria very kindly showed you cartoons rather than stomach churning pictures like these. But this is just to indicate, for example, a tumour in the stomach that would require removal of a large portion of the stomach, and a picture of a tumour there on small bowel. You can see it at the top there. And I think the other interesting thing about that, you can see that the surgeon's going to take a chunk out of the bowel, rejoin it, so that's going to be quite major surgery for this patient, but the tumour will be completely removed. I think just in connection with the drug treatments you were talking about, it's quite interesting to see. You can see lots of new blood vessels. Can you see all these little red lines feeding the tumour? And so the fact that we've got drugs that target blood vessels, you can see some idea of why they would be helpful in treating these sorts of tumours that develop and attract a blood supply to them in order to sustain their growth. How common are GIST? Well, we've heard that the incidence is about 14.5 per million per year. So that means in an area like Leeds, where you service a population of 2 million? 2.6 million. So there are going to be about 35, something of that order, tumours a year. But actually only a small number of those, 10, 11%, will be patients with metastases, and therefore patients for whom drug treatment is the only choice. A lot of those, the other 89%, will be patients who have potentially operable tumours. So most patients present with tumours at an earlier stage. Most patients will have surgery. A lot of those patients will be cured. However, some tumours will recur after surgery, sometimes, of course, years later. And what I'm going to be talking about is what we can do about that. How do we know who those patients are, who is most at risk of relapse, and what can we do to reduce that risk? What can we do? Put that the other way around. What can we do? We've got a cure rate for surgery. How can we improve the cure rate? And that's what we're talking about. So the risk factors for relapse really aren't too complicated. Most of us could have guessed what these would be. What's a bad tumour? Well, a bad tumour is a big tumour, a tumour with a rapid growth rate, a tumour that, for example, is so fragile that it breaks in the surgeon's hands. And we also know, and I'll come on to that, that some locations the tumours are more dangerous than others. So we can identify the risk factors for relapse, we can identify which patients are at highest risk, and therefore those are patients for whom additional treatments may be most effective or most necessary. And I'm going to show you a number of these sorts of graphs, so I just want to explain what we're looking at here. So this is a graph showing a percentage on the left-hand side, and of course 100% at the top, and that's where the study starts, and here it's after surgery, so 100% of the patients are alive having had their surgery, and then time is passing as we go along the bottom. And on this slide, these are years from diagnosis, so time's passing 5 years, 10 years, out to 25 and 30 years. And you can see that if you have a very, very small tumour, that red line at the top says less than 1.1 centimetres. So if your tumour was very small, and it was cut out completely, 100% of patients are alive at the time just after surgery, and you can see that 90% of them are alive 30 years later. That's pretty good. If you've got bigger tumours, you can see that the lines then start to drop off, and if you had a very big tumour, then actually there's a very high risk that you will have relapse within a 5-year period. And so from this sort of information, looking at tumours of different sizes, 1 centimetre, 5 centimetres, 10 centimetres, 15 centimetres, you can see that big tumours are much more likely to cause problems further ahead. Okay. So that's size. And the other thing that we talk about, which I mentioned, is the growth rate, and you've heard this as well, the mitotic rate. And this is what we mean by the mitotic rate. This is looking at a GIST tumour under the microscope, and you can see lots of cells there, and you can see these sort of little ovals here are actually the nuclei of the cells, and they contain your DNA, which is quite dense. And those cells are all just doing their business, but the little ones that are circled, you can see dense DNA, which is clustered up, because when a cell divides, it has to pull the DNA together and then double it so that the cells can divide. So you can see dividing cells there, those are called mitoses. You can see the dividing cells in the tumour. And when we look at the mitotic rate, we ask our pathologists to look at the tumour and to count the number of dividing cells, the number of mitoses. And you'll hear this talked about, the mitotic rate. And we ask them to look at 50 fields, so they have to look at different areas of the tumour under the microscope at 50 different fields, that is to say, looking down the microscope what you see, and count the number of mitoses. And you'll hear about that, and you'll hear numbers, and we put a lot of value on these numbers, but I would just point out that, of course, some areas will look very bland and quiet, some will look quite busy. It's quite difficult to get a good average on this, and of course, we all drive different cars. The pathologists have different microscopes, they'll have different size lenses, and so when they talk about 50 high-powered fields, actually in Leeds that might be slightly different from in Sheffield because they might be using a different microscope. They also might be processing the sample differently. If you imagine we're cutting very thin slices of tumour, if you cut a very thin slice of tumour, you might have a field like this. Perhaps in the lab next door, they're cutting rather thick slices of tumour. Well, actually, they're going to see twice as many mitoses if their section is twice as thick. So I only mention this because we have these numbers and we lay great store on them, but actually they're not cut in stone, they're not absolute. There's always a little bit of a fudge factor, and we have to be a little bit careful because although in trials we set down what size lens it has to be and how thick the sections have to be cut, actually in real life things aren't quite as clear cut as that. So that's how we measure the mitotic rate. And this is another of those curves, starting at 100%, time there going out for 25 years. And this is at the top, patients who had less than 2 mitoses. That's when they've looked at 50 fields. I sometimes said to a patient, it's like a farmer who's got 50 fields. How many black sheep has he got in all his fields of sheep? Well, if there's only 2 in 50 fields, that's not very many. And if you only had 2, then your chances of survival are, you're practically guaranteed a cure, aren't you? 90% at 30 years. But if you have 5, 10, more than 10, you can see that things start to get much more serious. So if you've got more growing cells, more mitoses, then we can pinpoint that these patients are at higher risk of further problems after surgery, even when the tumour is completely gone. It's not a big surprise to know that if the tumour is so friable that it breaks during the operation, it ruptures, then that's a bad thing, and there's a risk of spread and recurrence of that tumour. And then the other thing which is a little bit surprising, and we really don't know why, is that primary site differs. And the best site is to have a tumour in the stomach, I guess that could be easily taken out completely, and you can see that for the patients with the stomach tumours, they do best. And then there are other groups, small intestine, large intestine and colon, and then those extraterrestrial ones, the E-GIST that Maria mentioned before, they do worst of all. So the site also influences the risks. And people have developed various ways of putting these together to try and attribute a score for what's low risk and what's high risk. And this was really the first one that we used, which is quite simply using just tumour size. So is it less than 2 centimetres, greater than 10 centimetres, and combining that with mitotic count to say which are the lowest and the highest risk tumours, the ones most likely to cause problems in the future. This is another table that is often shown of the different, this is now taking into account the site as well as the number of mitoses and the size, and it's getting quite complicated. But you can see that using this, the risk of recurrence is as little as 0 or 2% for small tumours in the stomach with a low mitotic rate, but goes up to 90%, for example, for big tumours with a high mitotic rate. So it does divide patients up, and it allows us then to advise patients what their risk is and whether further treatment should be considered. And then there's an even more complicated way now where they're trying to map this in kind of 4 dimensions to have a different risk model, and this is getting quite sophisticated. But you can see that we try to work out for each patient what the risk is for them, so we can personalise and tailor the treatment to them. So that's what we've been talking about, risk factors for relapse. Can we identify the patients who can be reassured and told after surgery, actually, chances are you've been cured, no additional treatment is necessary, you can relax. And those for whom we're going to be saying, well, you know, there's a very high chance this will come back, and they're going to say to me, what can we do about it? And what we can do about it, or what we consider, is called adjuvant chemotherapy. Adjuvant, additional, so this is additional to surgery. Treatment, systemic treatment, that means treatment by tablets usually, in the treatment of otherwise localized tumours. And of course, in the past, surgery was the only treatment available for most tumours, but now we can give chemotherapy, hormones, biologicals, across all sorts of different tumour types. So this isn't just about GIST. Adjuvant therapy is something that applies to all sorts of different tumour types. And the theory is that even though you can completely resect the tumour, possibly there will be some cells that have escaped before you ever got there, and they're called micrometastases, and they could be treated by adjuvant treatment, either before the operation, neoadjuvant, or afterwards, adjuvant treatment. And this is applied to all sorts of different tumour types. And for example, breast cancer, and if any of you know somebody who's had breast cancer, these days most patients who've had an operation for breast cancer will be offered additional treatment, hormones, or Herceptin, or with chemotherapy, or a combination. And the reason is because these treatments will improve the cure rate. Surgery can cure some of the patients, additional adjuvant treatments will increase the cure rate. And as a brief example, this is about breast cancer. We can identify the patients at high risk because they have in their armpit swollen glands. And if they have no glands, their chances are that they'll be okay. If they have 3 or 4 glands, the chances get worse. If they have 20 glands, their chances are getting substantially worse. So we can identify the people at high risk, we can give them treatment, and this is an overview of adjuvant treatment in breast cancer. And here you can see the recurrence rate, so it gets, over the time, it goes up, and you can improve that with chemotherapy so that 10-year survival is 5 or 10% better in these different groups if they get chemotherapy. The cure rate has been improved. So going back to GIST, adjuvant treatment, what's available, which patients and tumours, how long should we be giving it for? You've already seen this figure from Maria. This is advanced disease, and this is the study that really showed us that imatinib was very effective. And of course, this is only going out to 3 years, but we now go out to 10 years, and we know that we can have very prolonged responses to imatinib. And as she mentioned, the control group there was actually old-fashioned chemotherapy, which is very ineffective, as you can see, whereas imatinib is extremely effective. So it's very effective in advanced disease. Chances are, we think, it should be effective in early disease too. So the first study that came out on this was an American study, the American College of Surgeons, this Corsage Study, and they looked at patients who'd had completely resected R0, R1 means they got the tumour completely out, positive tumours, so we know they were GISTs, and they were larger than 3 centimetres. That's actually not terribly high risk, but that's what they took. Larger than 3 centimetres, and they recruited 713 patients and randomised them to imatinib or placebo for 1 year. Placebo controlled, so they didn't know, none of the patients or the doctors knew who was getting which treatment, and they were going to look at relapse-free survival. And this caused quite a stir when it came out, because after 1 year the chances of relapse in the patients who had placebo in this group was relapse-free, so 83% of them were free of relapse, they were okay, compared to 95% who'd had the drug. Now the Americans looked at this and said, that's fantastic, we ought to have the drug. And most of us said, well, that's kind of what you'd expect it to do. It doesn't necessarily mean that this is going to be the right treatment for everybody. So this is looking at those survival curves again. 100% when we start because they've just had an operation, and you can see this is looking at relapse. So if they had imatinib, they were free of relapse. That's the top line, much longer than the ones who had placebo. But you can also see that lines start coming together after a couple of years, so it's kind of delayed relapse rather than preventing it, which makes you wonder, well, has it actually been all that helpful if it only delays it? The other thing is 2/3 of the patients never relapsed. So 2/3 of the patients, you could argue from this, have had Gleevec for a year who didn't need it. Now everybody knows that these drugs have a lot of hassle effect. You have to come up and down to hospital, you have to have blood tests, you might have side effects. Well, actually most people will have some side effects. So do you really want to give everybody this drug if 2/3 of them would never need it? So it's a consideration that we need to weigh up, and we need some more information than was available here. What it did show us was that the difference was really most marked if you had a tumour greater than 10 centimetres or perhaps 6 to 10 centimetres, but as you might expect, if you had a small tumour, probably the difference was hardly worthwhile. So the conclusion of the paper was that giving imatinib in the adjuvant setting, it's feasible, it's safe, it might not be terrifically fun for people, but it's safe and it's feasible. It delays relapse, works best in big tumours, but it didn't show any difference in survival, no improvement in cure rate. I've got a number of unanswered questions about this study. Firstly, can we identify which patients really need it? Are we going to give it to everybody? Do we know how long to give it for? They just did it for a year. And then, of course, because they looked at those preliminary results, they said, fantastic, give it to everybody. We've got no more information. One question about this study is, those patients who did relapse, could they all be rescued by giving them imatinib? The ones who didn't have it up front, they relapsed, were they all rescued? Is that why there was no survival difference? Because actually, you don't need to give everybody imatinib up front. You only need to give it to the ones who relapse. And then I've got this other niggling question, because Maria told you that if you take imatinib for long enough, eventually you get a new mutation and become resistant to it. And if you give it to patients who don't actually need it up front, does that risk mutations occurring earlier? Does that mean that when you do need the drug, it won't be effective? And of course, the bottom line is, does the imatinib actually improve the cure rate? Does it prevent death? So although this was tantalizing information and great news for Novartis, who were selling the drug, still quite a lot of questions that I want answered. And the next trial that came out was the Scandinavian trial. And this was a trial that was comparing, again, resected GIST, and they had a definition of what high risk was. They were either very big tumours, very high mitotic rate, or modest tumours with a modest mitotic rate, or ruptured tumours, so actually quite a high risk group. 400 patients, and they divided into imatinib for 1 year or imatinib for 3 years. So everybody got adjuvant imatinib. And at 5 years, this is looking at the patient's relapse-free survival, those who had not relapsed. So after 1 year, 47.9% were relapse-free, compared to 66% who'd be having it for 3 years. So 3 years treatment was better than 1 in terms of preventing relapse. We've already heard it prevents relapse, that's not news. But at 5 years, there was also a benefit in survival. And that's really important because it means we have improved the cure rate. It's not a lot, it's a difference, well, it's between 82% and 92%, but it was significant, and it suggests that actually, you can look at this both ways, either that the ones who didn't have it up front were not all rescued by imatinib. So actually giving the adjuvant treatment, the post-operative treatment with imatinib, does improve survival. And this was a really important trial and the one that's really driven the adoption of adjuvant imatinib in Europe. And this is looking at relapse-free survival, comparing the 3 years versus 1 year of imatinib, and you can see, not surprisingly, that relapse is delayed by having the treatment. But you can also see, it's not quite so big a difference, but you can see that the survival difference is emerging at 5 years, that the patients who had 3 years treatment are living longer. And that's really important for us. So it looks as though that has answered one of my questions. So from this trial, what do we conclude? Again, adjuvant imatinib is feasible, it's safe. 3 years is better than 1 year, both in terms of delaying relapse and in terms of improving survival. It does improve the cure rate. But I've still got this niggling question about, does the early use of imatinib increase the risk of resistance developing? This is something that we've got a little bit of information on from a European trial. And this is a trial that most British centres participated in. So again, looking at resected GIST, we're looking at high or intermediate risk patients. This trial recruited really well internationally, 900 patients who were divided into no further treatment or imatinib for 2 years. 2 years. So it wasn't placebo controlled, but nevertheless, 2 years treatment, nothing, which is the standard at the time, or imatinib. And the original plan was to use survival as a primary endpoint. But what actually happens, and you're aware of this now, is that because the treatment of advanced disease is so good, these patients live for years and years and years and years. And we've done this trial now 8 years ago it closed. And we're still waiting for results because everybody's still great. So it's very frustrating. It's because people are doing so well. And so we devised a new endpoint, which was imatinib failure-free survival. So this is patients who, the time from surgery to when they failed imatinib. So that might have been because they had it for advanced disease at relapse, or it might have been because they progressed through it. But it's to give us an indication of when the imatinib stops working, when the mutations start to take over. And here we're comparing relapse-free survival, imatinib failure-free survival, and then overall survival. Adjuvant and no adjuvant, so you've heard this story already now several times, that imatinib prevents relapse. So 5 years, the number of patients free of relapse was 63% in the controls, 69%, so as undoubtedly it is preventing and delaying relapse. That's consistent, we know that. Then this imatinib failure-free survival was, if anything, slightly better. It's not actually significant at this point, but if anything, slightly better in the imatinib group. And the overall survival, again, it's not significant, but it's certainly not worse. So that's consistent with what we've seen before. But that preliminary evidence suggests that imatinib is delaying relapse. It's not contributing to resistance. And from the other data, it appears that it is improving survival. And those are the survival curves taken from Paolo Casale's presentation at ASCO. So from our study, the EORTC study, our sort of preliminary conclusions of that early analysis, it's feasible, it's safe. It delays relapse. Early imatinib does not lead to resistance. So we think that actually it is safe to give. But it's too early in our trial to tell if there's a survival benefit. But I think we are quite encouraged by that data from the Scandinavian trial to think that, you know, we can improve the cure rate of surgery. So what about the future? At the moment, imatinib as an adjuvant treatment post-operatively is not yet NICE approved. They're looking at this again, but it is available on the CDF, the Cancer Drugs Fund, and it is being used throughout the country. So a lot of patients will be receiving adjuvant imatinib. We're giving it for 3 years, which is what they did in the Scandinavian study, and that's the best evidence that we've got. But in future, what about other drugs? Well, you've heard mention of masitinib, and there is a masitinib adjuvant trial. I'm not sure how well it's going. It's comparing masitinib versus placebo, and you might go, well, who'd want to be in that? They'd like to have imatinib. So it's in patients who were unable to tolerate or couldn't have imatinib. So I think that's going to be quite a difficult study to complete. But they're looking at it, and of course these other drugs that are available, we'd like to know about them in this setting as well. We still don't know really how long we should be giving it for, and they've been doing trials like this, looking at 5 years versus 10 years in breast cancer for years. And then there's a question that's raised, if you like, by Maria about what about these mutations? Can't we tailor the treatment rather better? The new Scandinavian trial, SSG12, is comparing, oh, that hasn't come out very well, 3 years of imatinib versus 5 years of imatinib. And the idea is that high-risk patients will have 3 years, that's our standard now, of adjuvant imatinib, and then be randomized to say, well, at that point, either we stop, which is what we normally do, or we give you another 2 years. And that study's up and running in Scandinavia, and we are looking at getting it set up in the UK. We're taking that to the NCRI group the week after next. So that's the current study that is ongoing, that is further exploring the question of where to go with adjuvant treatment of GIST. So in summary, there's a strong rationale for using imatinib in high-risk tumours, and we actually, as you can see, got quite clever now at determining by size, mitotic rate, site and rupture who the patients are at highest risk and therefore who've got the most to gain from this treatment. There's good evidence that giving imatinib for a period after surgery will delay or prevent relapse. There's some evidence, and I think it's quite good evidence, that it will improve survival. We don't yet know what the optimum duration of treatment is. And of course, we all say this, that more trials are needed, and we want to really maximize the information that we get from patients receiving treatment so that we can tailor treatments better in the future. So that's all that I wanted to say about this, but I think Maria and I both would be very happy now to take questions on any of the things that we've been talking about. Thank you for your attention.